Okay, as promised, we will move to the other side of the fence being the basement membrane, and diseases that are characterized by an active sediment, hematuria predominantly, obviously with some level of proteinuria, will be presenting morphologically with inflammation and or thrombosis. And as I mentioned to you, these two phenomena, these two pathologic phenomena often take place simultaneously. And when you have a lot of inflammation, you can be sure that there will be some aspect of thrombosis also in those microcirculations. So the glomerulitis, the inflammatory reactions, as you already heard also from Dr. Bonigio, can be due to inflammation from complement activation via the classical pathway, inflammation due to abnormalities of the alternative pathway of complement activation. It can be inflammation due to potentially antibody-dependent cell cytotoxicity, and this was not touched upon. And finally, it can be, like in rejection, classically, and in interstitial nephritis and drug-induced interstitial nephritis, a T-cell dependent and cell-mediated immune mechanism responsible for the inflammation. Those are, in general terms, and I will give you examples of all these four potential mechanisms by which you have an active glomerulitis that explains hematuria. And finally, hematuria can be due to fragility of the capillaries. Remember that the glomerular pressure is much higher than any other capillary, and therefore the glomerulus needs special help. And the special help comes in the form of special collagens, basement membrane collagens, that are expressed predominantly in the glomerulus. And if those collagen genes are defective, you have a defective assembly of the basement membrane in the glomerulus. They are fragile because they are thinner and they break easily, and therefore hematuria of glomerular origin can also be due not to an active inflammatory component, but due to fragility of the capillaries. So the acute nephritic syndrome obviously is a very unique form of presentation, and also the morphology of the acute nephritic syndrome is unique. And the two mechanisms, the two patterns of injury that are associated with the acute nephritic syndrome is diffuse proliferative, what today they prefer to call glomerulonephritis with diffuse hypercellularity, because there is no proliferation. These are not cells that are undergoing mitosis inside the glomerulus. These are inflammatory cells that accumulate in the glomerulus. So it's not a proliferative, so to speak, disease. It's an exudative disease. There is inflammation. And when the process persists in time, when the pathophysiology underlying the nephritic syndrome persists in time, the circulating immune complexes, or the lupus nephritis, or the patient has a persistent antigenemia due to hepatitis B or C, or persistent antigenemia due to endocarditis, or a shunt infection, or a chronic infection that the patient cannot get rid of, like Lyme disease, the disease moves from a proliferative pattern to a membranoproliferative pattern, which has a little more repair. And therefore, these two patterns of injury are one and the same, linked by time. If the patient has a self-limited disease, short-lived streptococcal infection, we call it diffuse proliferative. If the patient has a chronic infection or a chronic autoimmune disease such as lupus, usually the inflammation results in formation of double contours, and then we call it a membranoproliferative. Here you have an example of a diffuse proliferative, so-called, or exudative, or diffuse hypercellularity case. The capillaries are all occluded. In this case, they are occluded by cells, and the cells are mononuclear cells, like you see in the lobe here at around 3 o'clock, and many neutrophils, like you see here in the center or here. Neutrophils and mononuclear cells. At the beginning, neutrophils, very soon, monocyte macrophages move in. Characteristically, you see a little bit of IgG, but a lot of C3. And the electron microscopy shows subepithelial humps. I just told you that the lesion with hematuria is inside and not outside the basement membrane. Well, what you see here, and let me see whether I have, no, I don't have a higher power. What you don't see very often is the real actors of the inflammation. This is a neutrophil here sitting on the basement membrane. The endothelial cell has been stripped away by the inflammatory process. And here you see the neutrophil extending pseudopods toward the electron-dense deposit here and here and here. And these deposits are subendothelial. Those are the deposits that are driving the inflammation, not the humps. The humps are subepithelial deposits that if the patient has a lot of these, you can expect a lot of proteinuria, obviously, because you have podocyte injury, in addition to the endothelial damage, the subendothelial immune complexes. So we always focus on the humps in post-streptococcal GM. And the humps are like the politicians. They're always there when a picture is being taken because they remain there all the time. Or hospital administrators, they're always there when a picture is taken. So the real culprits for the inflammation are the subendothelial deposits, which of course disappear very quickly because the neutrophils, the macrophages, will engulf them, will take them away. That's what they are there for, to clean up the immune complexes. So this is becoming rarer and rarer, these kind of diseases, as you know. But in other parts of the world, where families live together in close quarters, you have a lot of streptococcal infections. We see other more unusual forms of infection. Here you have a patient that developed strongyloidiasis or recurrence of strongyloidiasis or reactivation of strongyloidiasis due to exposure to immune suppression. The patient was given steroids for some other condition, developed strongyloidiasis, disseminated strongyloidiasis, and an active immune complex disease. So here it's a worm that is triggering the whole disease with IgG deposited along all basement membrane in the inner aspect. And here you can see the electron microscopy, numerous subendothelial electron. Not a single hump is present here in this particular case. So diffuse proliferative, or with the new terminology, glomerulonephritis with diffuse endocapillary hypercellularity, in this case, due to this kind of infection. And not always do we have the source of the infection. In this particular case, I had 3 or 4 cases of strongyloides circularis. One was fatal. The patient died of that disease with an immune complex disease. This patient was lost to follow-up, and the diagnosis was made on the basis of the antibodies that were in very high titers present in this patient. Obviously, other diseases are more classic. This is a diffuse lupus nephritis. And again, I have to emphasize IgG, C3, C1q, classic activation of complement, the first group of diseases that I mentioned to you. Subendothelial deposits are present in this patient with lupus. Here you see an inflammatory cell sitting right next to the endothelium, trying to remove those subendothelial immune complex. The endothelial cell is engaged in the process by the activation of complement nearby, by the formation of the immune complexes, and therefore the endothelial cell upregulates adhesion molecules, and therefore inflammation ensues, not only because the complexes are right there and the anaphylatoxins are right there to attract the inflammatory cells, but also the endothelial cell has reacted probably by upregulating adhesion molecules. So diffuse exudative glomerulonephritis, or glomerulonephritis with diffuse hypercellularity, any form of bacterial infection. Recently, I had a case of a patient that developed from the children, developed fifth disease due to parvovirus, and we have parvovirus immune complex diseases as well. So bacterial infections, don't limit yourself to streptococcal infections. Any number of viral diseases, you're well familiar with hepatitis B and hepatitis C, with or without cryos, and other diseases can give you this also. And then the second group of diseases, of course, autoimmune diseases. So when you see an immune complex disease like this, think either acquired infections or an autoimmune disease. The other two we will discuss in a second. But those are the two large group of diseases with classic activation of complement. When the disease persists in time, you move from a purely inflammatory reaction in the glomerulus to repair. And the repair involves the formation of a second basement membrane with double contours. Then we talk about the membranoproliferative pattern of injury. The term membranoproliferative glomerulonephritis should be banned. It should not be used because it never is a definitive diagnosis of anything. You always have to dissect this pattern further. And therefore, I propose that this classification, which you will still find in many textbooks, should be eliminated. The same way the morphologic classification of focal sclerosis is completely useless. Here, the same is true. What you need to find out is what is behind the membranoproliferative pattern of injury. So you have hypercellularity of the tuft and you have thickening of the capillary wall with double contours. And the four groups of diseases that you need to have in mind with a membranoproliferative pattern of injury are immune complex diseases, like we already discussed in great part, abnormalities of complement regulatory proteins of the alternative pathway, thrombotic angiopathies that also lead to double contour formation, and deposition diseases, usually immunoglobulin paraprotein deposition diseases. And here you have an example of a classic activation of complement, C3 and C1q with IgG, a classic membranoproliferative pattern, double contours with more proliferation seen here or more inflammation seen here on the H&E. And this patient had a chronic infection. A shunt infection, most likely. And what you see here is the old basement membrane by electron microscopy. The podocytes, reasonably okay. Yes, a little disheveled, but otherwise okay. And then all this is added on. These are electron-dense deposits here, pieces of cells entrapped here, usually endothelial cell. And then the displaced endothelium has generated a new basement membrane here highlighted by the arrows. So you have two basement membranes, the old basement membrane, the asterisk, the new basement membrane, the arrows, in between electron-dense deposits that by immunofluorescence are immune deposits, immunoglobulin, with some kind of an antigen, and pieces of cells entrapped in this process. Here you have an example where you have even endoluminal deposits, large endoluminal immune complexes inside the lumen. In lupus, we would call this pseudothrombi, but this patient happened to have hepatitis C and a cryoglobulinemia. So the etiology is relevant. The mechanism that results in a membranoproliferative pattern is relevant for you to discover and not the pattern of injury. So hepatitis C, characterized by subendothelial deposits. Here again, there are some substructures. Usually the IgM is monoclonal. And there's also IgG here. The cryoglobulins are type 2, usually monoclonal IgM. And these patients in the long run can eventually develop a lymphoma or a lymphoproliferative disorder, in which case the whole process becomes independent of the initial infection. This is a 57-year-old woman with recently diagnosed myocarditis due to Lyme disease, presents now with hematuria, proteinuria, has serum creatinine peaked at 1.5, the baseline was 1. And here you see a well-preserved parenchyma. Something very recently happened. There is no chronic damage here. Hypercellularity of all, the capillaries are all occluded by inflammatory cells, mostly mononuclear cells, and then you can see double contours and thickened basement membranes in many, many capillaries. If you call this idiopathic membranoproliferative glomerulonephritis, you will never figure out what it is. So it is better to keep it as a pattern of injury and say we have to look for chronic infections and autoimmune diseases. IgG was present here in a continuous fashion around all capillaries, basically. C3, C1q, and subendothelial deposits, you see them here very nicely, and the formation of a new basement membrane under the displaced endothelium, the membranoproliferative pattern of injury with electron-dense deposits that by immunofluorescence are immune complexes. Lyme disease, and you see more and more Lyme disease, at least in the states, in the northern states here, that there was relatively little Lyme disease. Now we see more and more with climate change, we suppose. So immune complex mediated diseases can give you the membranoproliferative pattern of injury when the process persists, when the pathophysiology persists. And again, persistent viral infection, persistent bacterial infection, protozoal infection, other infections. And of course, the second group, autoimmune diseases, similar to what we discussed in the diffuse proliferative pattern of injury. The second group of diseases with activation of complement, but this time via the alternative pathway, are basically three diseases. Dense deposit disease, glomerulonephritis C3, and atypical HOS. Notice again the connection here. These are three manifestations of the same pathophysiology, which is abnormalities of the alternative complement pathway that can be either acquired or genetic. But again, the overlap is much more important than anything else. So yes, we like to pigeonhole diseases into particular little groups, little boxes. But there is a lot of overlap between these three modes, morphologic ways of presentation of the abnormalities of the alternative complement pathway. As already mentioned by Dr. Bonegio, the alternative pathway belongs to the native immunity. It's the more original one, and you have activation of this enzyme constantly in the body, making sure that all viruses are taken care of, making sure that all debris is being removed. So activation of complement is very important. And therefore, this enzyme, the alternative complement pathway convertase, or C3 convertase of the alternative pathway, is always active. It activates complement in small amounts. It generates a small amount of anaphylatoxins that cause the inflammation, and it generates membrane attack complex, potentially damaging cells. But in this case, it is a useful method of cleaning up damaged cells and invaders. Now, this can get out of hand because under normal circumstances, this enzyme is kept under check with factor H and factor I in CD46, which is cell-bound. These are two elements, enzymes and coenzymes that are in the fluid phase acting in the serum, whereas CD46 is localized on the cell surface to prevent this type of injury to the healthy cells. And therefore, we have a normal way of balancing the effect of this enzyme. Like everything in physiology, you have something that keeps it in balance. When you have a defect of these enzymes or these cell membrane-associated proteins like CD40, this becomes more active. Again, in function of this enzyme that activates complement, leading to C3a and C5a inflammation and leading to the membrane attack complex exaggerated. But you can also have acquired autoantibodies that recognize this and protect it from enzyme degradation, or an antibody against factor H that annuls its function. Or sometimes we don't know, but monoclonal antibodies very often interfere with this and create an upregulated function or an upregulated C3 convertase. And therefore, acquired mechanism, autoantibodies against some of these components, anti-factor B, for example, can give you this activation of complement. Now, in any given case, it is sometimes difficult to figure out what the mechanism is, but it is important to find out in any given patient. The patient has a molecular defect that is potentially inherited, or whether the patient has an autoantibody, or most importantly, whether the patient has a circuiting monoclonal immunoglobulin that is interfering with this function in normal physiology. So dense deposit disease affects predominantly children and young adults, but it can also affect older patients because there is the acquired form of the disease as well. Usually these patients have a circulating C3 nephritic factor. This is what it looks like. Variable proliferation inflammation, in this case it's a very focal lesion. You see many capillaries are open. The patient probably doesn't have a very active disease at this point. C3 is the only protein that we see by immunofluorescence. This, even though it's a very dense deposit called dense deposit disease, it is not an immune complex. So for many decades, this was assumed to be an immune complex disease, like all the other diseases that we knew are immune complexes. But these dense deposits are not immune complexes. They are modified, insoluble elements of the alternative pathway, predominantly C3. And since we stain routinely for C3, here it is. C3 only, no immunoglobulin G or A or M, nothing. So this is not an immune complex disease. This is the exaggeration, the pretty end-stage case of a patient, a nurse that at age around 50 became dialysis dependent with this dense deposit disease. A cousin of dense deposit disease is C3 glomerulonephritis or glomerulonephritis C3, depending on how you want. This was first described in 2006, so it's not that long that we know about the existence of this disease. We knew about the morphology of this disease, but we didn't connect it with the alternative complement pathway. And we knew it as MPGN, idiopathic MPGN type 3. Obviously, dense deposit disease was at the time called idiopathic MPGN type 2. So they existed, or we knew about the unique morphology of these diseases, but we had not connected them to the abnormal pathophysiology, namely the alternative complement pathway. Here, instead of very dense deposits, you have subepithelial humps that can easily be confused with post-streptococcal GN, which in this case, they are not. There may be triggers of an infection very often in these diseases, but this is not a streptococcal antigen that it is here. You have C3 deposits only, and these very waxy looking deposits with subepithelial humps. Notice again, relatively little inflammation at this point in time of this patient. These diseases, the activity, the functional activity of these diseases get triggered by intercurrent infections. And so if the biopsy is done between infections, between active disease, you will find a mesangial-proliferative pattern, mild focal inflammation or something like that. If you were to biopsy this patient with a flare-up of this disease right after an infection that triggers this, you will find a membranoproliferative pattern or mesangial capillary, depending on which side of the Atlantic you live. Complement is the only marker that is there by immunofluorescence. No IgG, no significant IgA, no IgM, and then these odd deposits. So in a classic fashion, you recognize them very easily. Here's a woman, a 31-year-old woman with a history of nephrotic syndrome and hypertension. You see the membranoproliferative pattern of injury, C3, no immunoglobulins shown here, kappa and lambda. These very odd-looking deposits, I couldn't even call them dense deposits, but they are waxy-looking, continuous and very large, in this case subendothelial, and of course subepithelial hump-like deposit. So this patient was analyzed for the presence of mutations of proteins of the alternative pathway. And in this case, nothing was found genetically. She had a C3 nephritic factor, which is an autoantibody, of course, against the alternative pathway convertase. And this was high, and there was evidence of activation or upregulation, if you want, of the enzyme, because the soluble membrane attack complex, the C5b29, was elevated in the circulation above the normal level. And therefore, here you have the antibody, an acquired form of this disease, glomerulonephritis C3. So The third member of this is atypical HUS, but remember I mentioned to you that in every of the other forms of this group of diseases, you will also find some level of endothelial injury. Look at this case. 88-year-old man. So obviously, we cannot talk about a genetic disease, especially when the kidney is perfectly well preserved in this case. He has a circulating paraprotein. And what does it show? Diffuse damage to the glomerulus. Every capillary is occluded, either by swollen cells, the eosinophilic stuff, or by few inflammatory cells that you can recognize in some of the capillaries. Inflammation and thrombosis going hand in hand. And here you see the inflammatory component on the right glomerulus with inflammation. Here you see mostly the thrombotic or healed thrombotic component on the left of this, in this particular glomerulus. No IgG deposited, only C3 along the capillary walls, and of course fibrin. Again, remember the connection. And here you can see already a subepithelial hump on this side of the capillary. On this side of the capillary, you have remodeling of the capillary wall without deposits, characteristic for a chronic thrombotic angiopathy. So in this case, you have coexistence of these two pathologic mechanism, thrombosis as well as inflammation, and the inflammation due to activation of complement via the alternative pathway because the paraprotein has interfered with the regulation of the C3 convertase of the alternative pathway. Either it has linked to it and protected from degradation, or it has interfered with the factor H or factor I or CD46 on the cell surface, generating a procoagulant state, if you want. So thrombotic angiopathies are another feature in which you see remodeling of the capillary wall, maybe with a little less inflammation as the other forms. And here you have a classic example of a thrombotic angiopathy. This patient has an antiphospholipid antibody, double contours, thickening of the capillary walls, fibrin deposits mostly, remodeling of the capillary wall with interposition of cells, but no electron-dense deposits in this case, and arteriolar changes like you see here and here, with either fibrinoid necrosis of the arteriolar wall or onion skin lesion. This is a classic example of onion skin lesion. Obviously, these patients have hypertension. And obviously, you will tend to or be tempted to attribute this disease to hypertension. Please don't fall into that temptation. Hypertension is a consequence of this vascular injury and microvascular injury and not the cause of it. And therefore, don't attribute this to hypertension, even though the patient may have difficult to control hypertension, but that's a consequence of this pathology and not the cause of this pathology. So thrombotic angiopathies can be viewed as direct endothelial injury. Obviously, you know about the Shiga-like toxin producing microorganisms. Many drugs these days are toxic to the endothelium, anti-VEGF therapy for cancer, cisplatin, bleomycin, the old one, gemcitabine, a new one on the block. Immune injury, antiphospholipid antibodies, of course. Organ rejection with antibodies against endothelial cell antigens can give you a thrombotic angiopathy. Then there are genetic and acquired diseases such as hyperhomocystinemia. Hemoglobinopathies can also be part of the thrombotic angiopathies. The genetic aspects of the thrombophilias are well established. And then you have genetic and acquired defects of the complement system, which belongs into this group of dense deposit disease and glomerulonephritis C3, both acquired as well as genetic. So don't forget thrombotic angiopathies to include in your differential diagnosis when the pathology comes back, a membranoproliferative pattern of injury, especially if there's no C3 and no immunoglobulin. That is a hint that you may be in front of that. Paraprotein deposition diseases can deposit in the subendothelium, disturb the endothelium, and therefore cause a membranoproliferative pattern of injury. This is much more frequent than you think. This condition is probably almost as frequent as an immune complex membranoproliferative pattern of injury, at least in our experience. And here you have an example. Massive hypercellularity of the glomerulus by H&E. Every capillary is occluded by mononuclear cells. Double contours, if you look carefully here, along the basement membranes. IgG, very prominent deposits along the capillary walls. Kappa, but not lambda. And if your pathologist doesn't use kappa and lambda routinely, you will never know whether a deposit is monoclonal or not. And therefore, this is absolutely imperative to do kappa lambda and potentially also subclasses of IgG. In the subclasses of IgG, you can see that in this case, it's a gamma 3 and not 1, 2, or 4 that is deposited in the kidney. So you have not only the evidence on the basis of the light chain, one and not the other, but also on the basis of the heavy chain, that this is a IgG3 kappa monoclonal immunoglobulin deposition disease with a membranoproliferative pattern of injury. Yes, it's a mouthful, but it tells you what the patient has and not something that you have to imagine when you get the biopsy results as idiopathic anything. So by electron microscopy, these look like immune complexes, and therefore you cannot tell them by immune complexes. Occasionally, the deposits look different, but not every case of paraprotein deposition disease will have unique features by electron microscopy, and therefore, if you don't do the subclasses by light chain and by heavy chain, you will never know. Sometimes you see tubular structures in these deposits. Sometimes they are organized, almost like fibrin gets organized. Sometimes they are even subepithelial. Sometimes they organize inside inflammatory cells in the form of crystals. So these paraproteins can form can fold in very pathologic ways, giving you substructures within these deposits. Now, very important, don't just think of myeloma and plasma cell disorders. Many, many of these patients don't have a multiple myeloma or a plasma cell dyscrasia. Many of these patients have a B-cell lymphoproliferative disorder, a CLL or a lymphoma. Sometimes the lymphoma is not even diagnosed because it's a peripheral lymphoma in one of the mucosas, the so-called Peyer's patches, you know. I'm going to get back at Bonegio about that comment that he made. Some patients develop lymphomas of the intestine that don't manifest themselves until years later in the form of a perforated gut or something, while the kidney has already undergone complete destruction by the paraprotein deposition disease. So these patients need to be worked up, not only for plasma cell disorders. If you do a bone marrow, they also need to be looked for clonality in the B cells. And this is often forgotten because you think a paraprotein has to come from a myeloma. Wrong. Paraprotein can come from a lymphoma as well. And therefore, these patients need to be worked up both for lymphomas as well as for. And so two of these conditions give you a proliferative glomerulonephritis, a monoclonal immunoglobulin deposition disease, or called light and heavy chain deposition disease, as well as sometimes these paraproteins act as a cryotype 1. And so cryoglobulinemia type 1 belongs into this group of diseases. So the membranoproliferative pattern of injury. Forget about idiopathic membranoproliferative glomerulonephritis, is that it does not exist. Trust me. You have to divide these diseases with this pattern of injury into immune complex diseases, infections and autoimmune. There is no other way in which you can have immune complex disease that isn't related to an exogenous antigen, infection usually, or autoimmune disease. Second, if the deposited paraprotein immunoglobulin is monoclonal by light chains and by heavy chains, and C3 and C1q can be present under those circumstances, you call it a paraprotein deposition disease. If there is no immunoglobulin by immunofluorescence and only C3, it's usually dense deposit disease or glomerulonephritis C3. Sometimes post-infectious glomerulonephritis can also present with C3 only, so the differential here also includes a late phase of a post-streptococcal glomerulonephritis. And finally, if there is no immunoglobulin by immunofluorescence and only a little bit of fibrin here and there, consider the possibility of a chronic thrombotic angiopathy. Let's move to the rapidly progressive glomerulonephritis. In my opinion, we have a lack of knowledge in this group of diseases, and you will probably see my bias as we go through this. This is characterized by rapid decline in renal function over several days or weeks, usually with a very active sediment, of course, red cell cast. And usually there is no edema and no hypertension because the installation of the inflammation is over many days or a few weeks. And therefore, the patient has managed to upregulate the sodium wasting channels in the nephrons that are working, and therefore the patient is not volume overloaded in general, as opposed to the acute nephritic syndrome, where you have volume overload. So the pattern, this flavor that you have here is a focal proliferative or necrotizing, usually glomerulonephritis, and then very soon this evolves into a crescentic glomerular. Also here, there's a time relationship between these two patterns of injury. The same differential applies whether you present early in the course of the disease with a focal necrotizing pattern, or if you present a week or 2 weeks later with a crescentic glomerulonephritis. The same discussion applies to both these patterns, and usually they go together. My bias is that these patients are due to activation of systems that do not belong to the classical pathway. This is an activation probably of an antibody-dependent cell cytotoxicity mechanism. The necrotizing lesion is telling you that something is inducing focal necrosis in the glomerular capillaries, or potentially cell-mediated through CD8 positive cytolytic T cells. But this is my bias. So in general, we recognize 3 types of crescentic GN. With linear staining, which we normally equate to anti-GBM disease, immune complex mediated crescentic GN, and pauci-immune polyangiitis, usually ANCA associated, at least in 70% or so of cases. The pauci-immune, no immunoglobulin mediated processes are usually, you can demonstrate in ANCA. And there are various clinical presentations of this. But remember, any other disease that we have discussed here, short of minimal change disease, of course, and focal sclerosis, can be associated with crescents. Even membranous nephropathy can be complicated by an additional crescentic GN, probably because those patients develop other autoantibodies in addition to the ones that cause the membranous nephropathy. And this is why I don't think this is necessarily a neutrophil-driven process like the theory from North Carolina has assumed for several decades now, that the anti-neutrophil cytoplasm antibodies are driving this process. I think there is more to the mechanism of crescentic GN, especially because many of these patients with focal necrotizing and crescentic GN have anti-GBM disease. They have an immune complex disease. They have some other form of injury, not necessarily activation of neutrophils by an anti-neutrophil cytoplasm antibody. But besides the mechanism, which I think is a very important and critical question, because we have no good therapy, specific therapy for this disease, I think it is relevant to eventually focus on the pathogenesis of focal necrotizing and crescentic GN as different from the other diseases that we have discussed. Morphologically, it's relatively straightforward. You have a focus here of necrosis with a few cells. This is fibrinoid necrosis of the tuft. And within few days, usually 7 days, the patients develop, or the animals that were studied with this condition, develop accumulation of mononuclear cells in the form of activated macrophages in the urinary space, which we call a crescent. So this is a cellular crescent, but very often you see little foci of necrotizing lesions in these crescentic lesions as well. Here you have a circumferential crescent that has completely injured and suffocated the tuft. You see, this is what is remaining of the glomerular tuft now, fragmented into 2 pieces. Focal necrosis here and a crescent here. Sometimes the crescents have multinucleated giant cells, that tell you exactly that these cells are mononuclear derived. They are derived from the circulating monocytes that have become activated, and we call them epithelioid cells or multinucleated giant cells or just activated macrophages. Crescentic GN. The crescent is usually associated with fibrin. If you do the immunofluorescence microscopy, fibrin is non-specific. Every crescent will have fibrin, the same way every exudative inflammation anywhere in the body has fibrin, cross-linked fibrin, and therefore this is just a very convenient marker to recognize the formation of crescents. By immunofluorescence, you can recognize the linear pattern of anti-GBM disease here, continuous, fine, very fine, linear ribbon-like. Notice here the crescent is negative for IgG. This is IgG staining. Here you see an immune complex disease. This patient has lupus that is crescentic. And on the right-hand side, you see no immunoglobulin, just background staining in a patient that has an ANCA-driven polyangiitis. So the immunofluorescence tells you apart. What is the relevance? When there's an immune complex disease, you have to get to the bottom. What is causing this immune complex disease? When it's anti-GBM disease, you may want to remove the circulating antibody quickly, especially when you want to prevent also other systemic manifestations such as pulmonary hemorrhage. And when it is partially immune, sometimes people also use plasmapheresis, but in Europe usually, in the States usually, these patients get treated with steroids and cytotoxic drugs and or rituximab these days. Anti-GBM disease is very, very characteristic by light microscopy, linear staining, continuous staining, ribbon-like. And this is an autoimmune disease. It's a limited autoimmune disease depending on the HLA of the patient and depending on the exposure to certain triggers. They develop antibodies that recognize a particular area of this long collagen alpha-3 molecule, collagen 4 alpha-3. One particular epitope becomes immunogenic, and that's when the patient develops anti-GBM disease. Here you have an example of a crescentic lupus nephritis, and you can see the crescents look exactly the same as an anti-GBM disease or an ANCA disease. So the crescent is identical. It's the same cell response, inflammatory response to some bound immunoglobulin. Here you have an immune complex with crescents. This is an IgG, a very early phase of lupus, but with a very active crescentic component, and therefore something is upregulated in patients that develop crescents, and I suspect it is the NK activity. This patient with lupus then also has tubular reticular inclusions and relatively few deposits. In this case, deposits only limited to the mesangium. So patients with lupus, like this class 2 lupus, underlying the disease, can develop a superimposed podocyte disease, minimal change disease. They develop another antibody that is responsible for the added pathophysiology. In this case, the patient probably developed yet another antibody that causes or that has triggered this crescentic form of injury. When you see an ANCA disease with very high titers of ANCA, always think of a drug-induced ANCA. And this is very important. I cannot stress enough this. In the literature, it's not well represented. These patients very often have also immune complexes. And all these drugs that can cause ANCA disease can also cause lupus in some patients that are so predisposed. And therefore, not infrequently do we see patients with an immune complex disease and crescents. In this case, we have immune deposits along in the mesangium and along the subendothelium. In this patient with an otherwise ANCA-driven disease, but the immune complexes that are also present are hopefully telling you that you should look for other autoantibodies in patients like this, antihistones, ANA, anti-double-stranded DNA. And very often these patients with drug-induced ANCA have these other telltales of this. So this is the classic explanation of crescentic GN for ANCA patients, activation of neutrophils, and somehow activation of endothelial cell with eventually accumulation of macrophages in there. The interesting thing is that neutrophils are not an important component of focal necrotizing and crescentic GN, and this is why I think there is something missing in this theory of diseases. Finally, in the last 5 minutes, very briefly, the diseases that you have hematuria in the absence of full nephritic syndrome or rapidly progressive GN and asymptomatic hematuria. And here you have these diseases are mesangial proliferative, and if there is no inflammation, frequently the underlying cause of the hematuria is a basement membrane abnormality. During the active phase of the disease, these patients with mesangial proliferative GN, usually IgA nephropathy, also can have focal proliferative and crescentic components to this. I'm not going to take too much time here. This is a mesangial proliferative pattern of injury with very prominent IgA deposits in the mesangium, electron-dense deposits. And yes, during the active phase, the patient very often have a focal inflammatory lesion. Even crescents can occur in this condition. And this is what has been noted by many, many authors, that IgA can present with variable phases or with variable expressions. Normal glomeruli by light microscopy. When there is focal proliferative or necrotizing lesion, usually the patient has some form of acute nephritis. When the patient has a rapidly progressive course, usually you're going to find crescents in this case. And very often the patient comes to you when the patient has advanced chronic kidney disease, in which case you're going to find a mixture of variable patterns of injury depending on the activity of the disease. You will hear about the pathogenesis, the underglycosylated hinge area of the IgA molecule that the system is incapable of clearing effectively, and therefore IgA that is underglycosylated will accumulate in the mesangium, potentially triggering episodes of activity. And what triggers those episodes of activity, those focal necrotizing, those crescentic episodes, is not clear. So here's a classification. The classification by Haas is mimicking the lupus classification, which has fallen out of favor. And now we use the Oxford classification, with focuses on the mesangial expansion, on the endocapillary inflammation, on the presence of segmental sclerosis, on the presence of tubular atrophy, interstitial fibrosis, and now the presence of crescents. And therefore, each time you have one of these, it gives you bad prognosis. And by focal sclerosis, I mean focal and segmental scarring, which is the type of scarring that we mentioned happens in patients with IgA or with inflammatory lupus lesions or with ANCA disease. So we focus on those aspects. We quantitate or semi-quantitate them, and depending on the score, 1 or 2 in most of them, except for some that have a score of 2. As you can see, T, tubular interstitial disease, can go up to 2. And the higher the score, the worse is the ultimate prognosis, which is kind of intuitive. The more tubular atrophy, interstitial fibrosis you have, the less likely is the kidney to survive. The more inflammatory activity you have, the less likely it is for that kidney to survive long. And the more segmental scarring you have, the more advanced the disease. So it all boils down to that. And finally, capillary fragility. I cannot emphasize enough the morphologic aspect that need to be paid attention here. These patients have hereditary abnormalities, usually of the type 4 collagen. And there are a bunch of other genetic abnormalities, but most of them are really affecting the basement membrane collagens. And in the glomerulus, we have not only at one point collagen alpha 1 and collagen 4 alpha 2, but they get replaced by these more cross-linked collagen 3, 4, and 5. And any defect in any of these autosomal genes or this X-linked gene can cause either thin basement membrane disease if you inherit one defective copy, or progressive Alport syndrome if you inherit the X-linked defect in males, or you develop the both autosomal from both parents. This is the pattern that you see on the basal membrane with hereditary nephritis, Alport syndrome type, X-linked type. You see the fraying of the basal membrane. There is no lamina densa left. It becomes basket weave appearance. And the more common form is, of course, the thin basal membrane disease. And this is clearly autosomal. The hematuria, persistent hematuria gets inherited as an autosomal dominant effect. The chronic kidney disease as an autosomal recessive. These capillaries are fragile, they break easily, and hence they cause hematuria. And if they break fast enough, you have chronic kidney disease. If there is a relatively benign genetic abnormality or heterozygous, they break slowly and are compatible with a normal life.